You know, this meeting would not be possible if it weren't for all of your amazing support, the EIIC support, and the tireless attention to detail by HRSA's EMSC team. I'd like to just take a moment and acknowledge Jocelyn Hilbert and all of her work to bring us together. I think of Jocelyn sets up this meeting with so much care and so much attention. And she's doing that with the strong support of Sophia Arias and the whole EMS team, including Yolanda Baker, Melissa Esmiro, Laura Ludwig, Patty Fanflick, and of course, T. Morrison-Quinata. So I just want to say thank you guys for getting us off such a great start. Our next speaker is our own Theresa Morrison-Quinata, aka T, who we all know and love that way. She is the HRSA EMS branch chief, and her remarks will be followed by Dr. Kate Remick and Dr. Charles Macias, who lead HRSA's EMSC Innovation and Improvement Center. So I'm going to hand it over to you all now. Thank you, T.
Thank you very much, Dr. Kinsman. Can you hear me? I too cannot see my slides, so I appreciate help with moving the slides forward. I'm still on slide 1. Folks can hear me?
Yep, we can hear you, T.
Great, thank you. So first, I'd like to echo Dr. Warren and Dr. Kinsman's sentiments to thank our EMSC grantees and our stakeholders for joining us this week for our 2021 EMSC conference. On behalf of the EMSC and Regional Pediatric Pandemic Network, one of our newest programs, on behalf of our team, we hope you are safe and are doing well. It has been a challenging year and a half since the onset of COVID, and in recent months, the Delta variant, hurricanes, and other disasters. We admire your commitment and your ability to be agile by being able to understand, adapt, and change in an ever-evolving environment in your home states while continuing to forge new paths. Since I joined the EMSC program 21 years ago, I have learned so much from each of you, and for some of you, from your predecessors, through the sharing of resources and the dissemination of lessons learned. We remain committed to maintaining our partnerships to expand opportunities to support the states, to support our researchers, and to support as we look to generate evidence to support the path forward, our path forward. Slide 2, please. The EMSC program is guided by its 1984 legislative mandate, and I copied this from Dr. Warren, so I was following his lead, to expand and improve emergency medical services for children who need treatment for trauma and critical care. EMSC continues to lead national pediatric readiness initiatives across the country through its National Pediatric Readiness Project within emergency departments, and now as we forge ahead in looking at our pre-hospital system and learning to have both of those systems work together seamlessly is one of our ultimate goals. Next slide. So HRSA is very pleased to announce its awards and released awards for the Rural Expansion Supplement. I must give a lot of credit to Laura Ludwig, Jocelyn Hilbert, and our state partnership team that designed this project. As a result of creating a program to support the states, competition was released. And as a result, 4 states were selected through a competitive process. The goal of this project is to ensure access to age-appropriate, high-quality care. The objectives, as always, is an expansion into the areas of rural, remote, and tribal areas. Our objectives are to increase the number of hospitals that are recognized by a state region, or territorial pediatric medical recognition program, and or to increase the number of pediatric emergency care coordinators. The awardees that were just announced just earlier mid this month is the regents of the University of Colorado, Kentucky's Community and Technical College System, Tennessee's Vanderbilt University Medical Center, and Wisconsin Department of Health Services. Congratulations to you and to all who took the time to compete for this funding opportunity. We look forward to you developing model programs to help advance us further. Next slide. HRSA also awarded the Regional Pediatric Pandemic Network. This program is housed within the Emergency Medical Services for Children branch, and its purpose, as set by Congress, is to coordinate among the nation's pediatric hospitals and their communities in preparing for and responding to global health threats, including the coordination, preparation, response, and real-time dissemination of research-informed pediatric care for future pandemics. The appropriation was $10 million per year, and this project is expected to run from September 1st, tomorrow, until August 31st, 2026.
Hello, everybody. Sorry for that little technical challenge. We wouldn't have a meeting without a good old technical challenge. The slides we'll be sharing key slides with you. Inadvertently, a different set of slides was put up, and I'm going to hand it back over to T to finish off. Thank you.
Thank you, Dr. Kinsman, and thank you for bearing with us. I am the lucky person to go through the glitches at this moment, so bear with us. So in continuing where I was, going through the HRSA awards for the Regional Pediatric Pandemic Network, let me just spend 1 or 2 more seconds in recognizing the enormous feat that these children's hospitals will be collaborating to lead the network. I want to truly recognize who they are and not skip through that. So it is the University Hospitals Cleveland Medical Center, Rainbow Babies and Children's Hospital, the Regents of the University of California, San Francisco, Benioff Children's Hospital, University of Utah Primary Children's Hospital, St. Louis University, Cardinal Glennon Children's Hospital, and the University of Louisville Research Foundation, Norton Children's Hospital. Thank you so much to all of you for taking the time to apply for this project and for being selected and leading this effort, especially amid our current pandemic. I want to also echo what Dr. Warren and Dr. Kinsman had said in recognizing and appreciating folks that have brought us here today and have continued to forge our path forward. The EMSC program grantees and stakeholders, our emergency personnel, federal and national partners, our meeting planners to include HRSA EMSC staff, our EMSC Innovation and Improvement Center, our EMSC Data Center, the National EMSC Data Analysis Resource Center, all the planning committee members who have dedicated and volunteered their time. Much of what we do in EMSC is volunteer time, and our speakers and moderators. Please continue to stay with us throughout the day and for the 2 days that follow. We have a great lineup planned, and thank you so much for your time. If you need to reach me, here is my contact information found on the last slide. And I will, in the interest of time, I'll turn it over to Dr. Macias and Dr. Remick. Thank you so much for your time today as well.
All right. Good morning, everyone, and thank you for being here today. We'll just jump right into the next slide. Just want to start by saying you are a critical mass, and we're so grateful to you for joining us today and over the next few days. You all are the light workers that are reducing childhood death and disability, helping to redesign our healthcare systems and transforming our healthcare landscape to better meet the needs of children. We do this as a unified front across 58 states and territories. We are a team of advocates, innovators, conductors, researchers, and educators, pushing across the continuum of care to strengthen our bonds and demonstrate our continued presence. Go to the next slide, please. Over the last 3.5 decades since EMSC was born, we as a team have driven exponential growth in pediatric emergency care. We've experienced a massive expansion of pediatric evidence-based guidelines due to the work of PCARN researchers and others. We have areas of the country with intense commitment to delivering high-quality pediatric emergency care and the development of many innovative approaches, overcoming challenges in system design and care delivery, the hero kids to name just one. Yet among the 30 million children who seek emergency care every year, we know that unevenness still exists, and therefore our work is not yet done. While over half of all children now have access to pediatric-ready emergency departments, we recognize that those children living in rural and remote areas are experiencing hospital closures and resource challenges. While numerous community EDs and EMS agencies have demonstrated excellence in care that meets or exceeds that of children's hospitals, and at times set the standard for pre-hospital emergency care, other children are experiencing prolonged pain, lags in treatment, and excessive radiation. Last, we know that such differences in care indeed lead to differences in outcomes. Outcomes such as mortality, that by all accounts are rare, less than 4% among children, but pronounced at the fringes of our emergency care landscape. This variability in care and disparities in outcomes is the challenge that we are all poised to face. The work you all have undertaken over the last 3 decades is immense, from education to toolkits, program development to care guidelines, and you can flip through the slide, advocacy to collaboration. We are a team of diverse professionals, leaders, and change makers focused on a singular mission. The transformation you have created in the emergency care space is driven and built upon these core elements: culture, collaboration, innovation, improvement science, communication, evidence-based, toolkits, advocacy, analytics, and marketing. Next slide. If only our path were simple. As you've heard, our everyday world is changing and growing increasingly more complex. This too is altering our healthcare landscape, where we now live predominantly in a virtual world. As a country, we're growing more and more reliant on internet capabilities that still do not reach the far corners of our community. As we have rapidly transitioned to online work in school, patient care, and social gatherings to overcome the challenges of pandemics and natural disasters, the health and well-being of our communities has at times suffered, and you or we, our colleagues, are all experiencing increased stress, blurred work-life balance, a national epidemic of mental illness, and a continued widening of well-known disparities. Next slide. Fortunately, we are not alone. Through collaboration, as you heard from Dr. Warren, we have demonstrated not only a recognizable footprint, but resilience. With partnerships, as you see here, partnerships with professional societies such as AAP, ASAP, ENA, American College of Surgeons Committee on Trauma, and the National Association of EMS Officials, as well as over 30 academic institutions, state departments, federal alliances, and most importantly, families, we together hold a shared mission and dedication to the future of our children. Because of this, we will continue to accomplish great things. And at this point, I'd like to turn it over to Charles to introduce our newest partner.
And with all these partnerships, we are indeed forging new paths. The Center for Pediatric Everyday Readiness, as T described, the Regional Pediatric Pandemic Network, we welcome into the EMSC space. Who is the RPPN? A network of 5 children's hospitals described previously, but as well an integrated network of networks. The ASPR, Assistant Secretary for Preparedness and Response, West Coast Disaster Center of Excellence, as well as the ASPR Eagle and the EMSC Innovation and Improvement Center. Our goal is to focus on the improvement of everyday readiness. With this network, we recognize that the best way to prepare the nation's children and families for global health threats is to prepare for pediatric everyday readiness, for daily emergencies, for mass casualty incidents, for global health threats, such as the pandemic. And with that, we recognize that the strengths that currently exist within the networks or within the domains, the work groups that currently exist within the EIC can be magnified through equity, analytics, quality improvement collaboratives, pre-hospital-based care, hospital-based care, trauma research, knowledge management with an EIC focus on expanding dissemination of prioritized work, especially that of the PCAR network, knowledge management, advocacy, and the support of state partnerships. Through the Asper Eagle strengths that have been demonstrated in telehealth and facility recognition, preparedness assessments, and understanding legal ramifications of disasters across state lines, of health information portability, and of capacity and capability monitoring through pediatric coordination centers. Through the Asper RAPM group, with their focus on CBRN, infectious diseases, deployable assets, or PDART teams, and drills and exercises, and 2 new domains to the EMSC space, an infectious disease committee or advisory board that has enhanced disease surveillance capabilities, and a focus on community and medical homes led by the American Academy of Pediatrics. And finally, 2 new advisory boards, the RPPN Steering Committee, as well as a new federal advisory board bringing together public and private organizational leaders to improve situational awareness and align activities before those activities are undertaken.
Each member of the EMSC family plays a key role in transformation. PCARN has uncovered the emergency care interventions and processes that lead to improved outcomes. Targeted issues grants have reinvented how we conceptualize systems of care. NEDARC has undertaken massive national effort to prove through analytics the impact of our collective efforts. State partnerships have gathered diverse teams, forged partnerships, and developed best practices for implementation. And the EIC has integrated improvement science and knowledge translation into national collaboratives to drive EMSC efforts into practice. As we welcome new partners, EMSC provides a historical lens of lessons learned and best practices. What we'd like to do now is to highlight several of the key initiatives and successes of our work, both what we have accomplished and that which is on the horizon. Still today, trauma is the leading cause of death in children over 1 year of age. And across our EMSC family, we have contributed immensely to this work. PCARN has helped in the generating of heads and C-spine validated decision rules, as well as the intra-abdominal injury algorithms. Through EIC, we are working towards developing a trauma triage toolkit, developing imaging guidelines, integrating head trauma into peak and pediatric readiness quality collaboratives. Through targeted issues and Dr. Newgard's work, we're analyzing pediatric injury and outcomes data and integrating head trauma into the National Peds Ready Quality Initiative. Through our state partnerships, we have outreach and coordination across our trauma systems, optimizing interfacility transfers, and through our partners, we're grateful for the development of trauma center verification criteria, data collection mechanisms, and through the development and reestablishment and revision of the CDC field triage criteria. Next, within the world of telehealth, as we move towards this virtual world, we know over the last few years, there's been over 150% increase in telehealth visits. Through the EIC, over this last year, we launched the Telehealth Collaborative of 8 state and territory teams, which will be moving towards a community of practice. We now have a telehealth toolkit through our partners within AAP, Family Voices, AMCHIP, and the Office of the National Coordinator for Health Information Technology. We now have family resource centers, collaboration and support, and even ECHO programs. The Office of Advancement of Technology and the telehealth resource centers within HRSA have provided immense support. We're looking forward to the partnership with RPPN and ASPR that will have the inclusion of telehealth and disaster planning. And finally, the state partnerships that are helping us to develop these best practices in telehealth and telemedicine resources through ED-EMS integration and alternative destinations. Next slide. Mental health, as we mentioned, is of epidemic proportions. We've seen a 60% increase in child mental health ED visits. Through the work of PCARN, we now have evidence to support suicide screening, specific suicide screening techniques within the ED setting. In the EIC, we're working to integrate that into our pediatric education and advocacy kits and develop a mental health QI collaborative that will launch in the next year. Our targeted issues work is integrating the suicide screening and QI efforts. We have prior work from people like Dr. Fallett, who integrated COPE into our work in the emergency care space. We look forward to integrating mental health in the RPPN and ASPR network. We have HRSA to thank for a critical crossroads toolkit. AAP and ASAP continue to promote and strategize around mental health needs, and our state partnerships for mapping out mental health resources and conducting outreach. And then within the world of pediatric readiness, as you've heard, we still know that over 80% of children still seek emergency care within their communities. Without the support of state partnerships to increase engagement and develop pediatric medical recognition programs to better integrate the workforce and PECs, NEDARC to launch these large national assessments for us to be able to evaluate pediatric readiness, HRSA to offer opportunities for collaboration across federal partners, our professional societies that have integrated pediatric readiness priorities within their organizational structure, PCARN that continues to promote that evidence generation. Through EIC, we're launching these QI collaboratives, and through our targeted issues grants, both on the pre-hospital and hospital side, is to really continue to promote efforts related to pediatric readiness.
And recognizing that 25% of victims of disasters are children and their families, work is ongoing with the EIC through our disaster collaboratives now in their second phase and the establishment of disaster regional measure scorecard. HRSA, RPPN are establishing a pediatric voice, expanding those networks, enhancing a coordinated response across the network of networks. ASPR is working through the Pediatric Disaster Centers of Excellence with best practices for disaster coordination, and our state partnerships are identifying regional resources, engaging in surge planning, working in partnership with our professional societies, including our Pediatric Disaster Council and AP-based ECHO education. Our EMSC priorities include overcoming disparities, really providing equity in the outcomes that we see to optimize the health of children and families. Our state partnerships are expanding the EMSC activities of rural and remote communities to eliminate geographic disparities. NEDARC is participating in the evaluation of emergency care access. Our professional partners are integrating all of these priorities as key strategic initiatives within those professional societies. HRSA EMSC is collaborating with Rural Health and Indian Health. PCARN is assessing for disparities in clinical practice. The EIC is developing an equity, diversity, and inclusion framework, and we have several targeted issues grants and other research-related activities that focus on facility level and patient demographics in QI efforts, really understanding the variation in clinical outcomes. It has been said over 2 decades ago by Sir Cyril Chandler that medicine used to be simple, ineffective, and relatively safe. Now it is complex, effective, and potentially dangerous. And indeed, it is complex, but the EMSC space is embracing the complexity and making it less complicated. And we do this with the foundation of the assets across the EMSC space. EMSC grantees are forging new paths to introduce and integrate new emergency management partners such as the RPPN, overcoming healthcare complexities in a digital-heavy society with e-medicine and telehealth, growing our capabilities in communication and dissemination with the knowledge management domain, our toolkits and our partnerships across North America, sustaining high levels of passion and engagement to overcome the workforce as workforce stresses, as well as really expanding the footprint and identifying our brand within the EMSC space. All of this is really focused on developing a footprint that helps us to collaborate, a footprint that aligns with one vision, one mission, and one strategy across the EMSC assets. And we do this with an understanding that we do this for the betterment of our outcomes for children and their families, all with laser focus. It has been said in an African proverb, if you want to go fast, go alone. If you want to go far, go together. I would argue that in fact, through the EMSC program, as evidence by this map of existing and soon to be pediatric emergency care coordinators, almost 1,500 pre-hospital and hospital-based PECs registered in the Pediatric Workforce Development Collaborative across the EMSC space, EMSC is moving fast and going far. Welcome to all of the grantees and welcome to the HRSA EMSC All-Grantee meeting. Can I turn this over to you?
Hello, everybody. Thank you so much T and Dr. Remick and Dr. Macias. We so appreciate that welcoming, exciting, and ready to roll. We are running a little bit late, so if it's okay with everybody, we're going to go right into the next meeting. And I just want to take a moment and also acknowledge our work with Luis Gonzalez at the EIIC. We wouldn't be, he helps coordinate this whole meeting, and we wouldn't have been able to do it without him. And Joss and he, I think, are partners in crime in this wonderful endeavor. So thank you so much. And I will hand it over to the next set of speakers.
Thank you too. Great job.